Welcome. In this conversation, we're going to be talking about prescribing practices, and particularly we'll be focusing in on opioid prescribing. This is the basic statute that talks about a physician prescribing medications. It will also include podiatrists and nurse practitioners, physician assistants, and so forth. Um, the textbook will give you much more detailed discussion of each of these statutes. Much of that discussion is probably historical, and that almost, certainly we're moving towards, if not completely, in many practices, using electronic prescribing, and that has really reduced the amount of challenges for prescribers. There is, nuances, of course, in prescribing. Virginia, like other states, allows a prescriber to prescribe generically or specifically for a name brand drug. The goal, of course, is to use as many generics as possible to reduce cost. In the 1980s, 1990s, there was a move towards assuring that patients did not suffer pain. That perspective was incorporated into the Joint Commission, as well as by the medical societies, that no patient should suffer pain. That pain was the fifth vital sign, and that had to be documented by the physicians and the medical staff. And you will still see a whole range of happy faces and sad faces in a chart, and the pain scores of 1 to 10 as to how much pain a patient is in. Any of you who have been on the clinical side will appreciate that those pain scores are terribly subjective and are often 10 out of 10, regardless of what the situation is. I invite you to reflect upon your reading of Ivan Illich's book as to pain and its role in the progress of man, whether or not we should have taken that perspective that pain should entirely be eliminated from practice. However, the pendulum did swing out there, and this statute was enacted, as it was in many states. This was geared towards the goal of treating terminally ill patients in particular, that they may need more than the usual dose of morphine or other pain medication, so that for palliative care. Likewise, an additional statute was enacted in 1995 to allow a physician to prescribe kind of whatever dose was needed for a patient to have pain relief based on their circumstances. I'm not going to go into great detail about these statutes, but it gave liberty to the physician to really prescribe on a case-by-case basis what medications were needed. However, the regulations required, or regulations and that was set forth in spring of 1998 by the Medical Society of Virginia and published by the Board of Medicine, allowed this sort of case-by-case use of pain medications in whatever dose was necessary, as long as scrupulous documentation was undertaken, that there was a valid physician-patient relationship, that the physician was using the amount of medication necessary but not more than necessary, and that the physician was continually looking for alternatives with the patient that were non-medical. So we started to see a bit more tightening of prescribing. The goal was to alleviate pain, but not overprescribe. By 2003, we saw statements like this, which I think were actually somewhat prophetic, in that there was a huge movement with a lot of emphasis from the pharmaceutical companies to be prescribing pain-relieving medications in ever more powerful formulations. But some were already questioning in 2003, where does this go? How's this play out? And you'll see here, he was pointing the finger at the academics and the manufacturers already. So if you are a healthcare provider and you're prescribing, there are certainly regulations and statutes on point that really try to steer you away from providing prescriptions for family members, for the office staff, or the hospital staff, or the administrative staff. I mean, and particularly for yourself. The way that many physicians find themselves caught by the Board of Medicine in the regulations is one has to establish a valid physician-patient relationship in order to prescribe. And the board has said you can't have a valid physician-patient relationship with yourself. With EMRs, prescribing has become more limited for family and friends because you have to, in most charts, have a chart set up for that family member or that friend. And that is a whole administrative process that one can't do as easily as they used to by simply calling a pharmacy or by simply handwriting a script and handing it to someone. We continue to have problems, and in your readings you will see the opioid prescribing crisis. I'm sure you heard about it in the popular press, if not the professional press. The challenge is that there are chronic pain patients out there who validly need pain management. So we can't abandon those folks. We can't entirely stop prescribing opioids. But we do have to deal with those who abuse substances and those who are dependent patients now because of having been started on medications. And then, of course, we have those who just think they are, the somatizers, who may carry their own psychiatric diagnosis for a disorder that they have, in essence, they become dependent upon the medications. One of the efforts to reduce the amount of prescriptions that have been written is the prescription monitoring program that is very active in Virginia, but is also present in almost all states, and they are now starting to share information across state lines so that a physician now is required, before they write a prescription for an opioid, to check the prescription monitoring program and to see if this patient has received other prescriptions from other providers and kind of the quantity and when, to see if they are receiving more pain medication than would be indicated. That is an effort to reduce the challenge of physicians who may have multiple physicians who are prescribing, or the doctor shopper. And in the old days, here in the Richmond area, there is a main street on the south side referred to as Midlothian Turnpike. From time to time, a patient would start at one end of Midlothian Turnpike and work their way down the road to all the doctor's offices collecting scripts for pain medications. The PMP and other approaches don't reduce the challenge that we have with angry, threatening patients who come in and bamboozle the doctor into prescribing for them just to get them out of the office. And the restrictions on opioid prescribing don't really address the need of the terminally ill who may need these pain medications for comfort. The good news is that there does not seem to be much of any move towards restricting pain medications for these patients, for the terminally ill patients. But still, the documentation is required, and the disposition of those drugs must be documented very carefully. There has been more than one situation where a healthcare worker has kind of collected the remaining doses of morphine for a deceased patient and has not properly disposed of those. The provider quite often may find themselves in a emotional situation where they may be feeling sorry for a patient. They may think that they are rescuing a patient, and they also may perceive themselves as just knowing more than anybody else, that they can manage these pain medications more cleverly than the average physician. More than one doctor has lost their license because of those situations. Occasionally we see physicians who start out prescribing and get into a situation where they keep prescribing because of and that may be because of a boundary violation with a patient. It may be because of a covering up a complication that they've not explained to the patient. Lots of different scenarios where the physician just kind of keeps digging themselves deeper in the hole. The challenge for lots of healthcare providers, of course, is setting boundaries. It may be that you take the same medication yourself for a chronic pain disorder that you think that, since you can handle that dose, the patient can handle that dose, and you understand the condition that they're suffering. It may be that you are embarrassed or concerned that if you stop prescribing, what the patient will do. If you've crossed the boundaries with the patient, there's been certainly more than one drugs for sex scandal out there in the world. And sometimes it's just a matter of you don't want to lose this patient. You are very successful in your pain management practice, for example, and you want to make sure to keep doing that. And sometimes it's just plain old lack of attention. You keep writing scripts because you just don't connect that this patient was here last week and they're on the phone now wanting a refill of a prescription that should have lasted them for 30 days. You just didn't notice. That brings us to the end of our brief conversation about prescribing practices. For those of you who may not be a gardener, this is a poppy. This is from which opioids are refined. My grandmother used to grow these quite a lot, but I don't think she ever distilled down any opium. It's like many other plants. Poppies by themselves are not dangerous. It's a matter of what you do with them. But anyway, thank you all for joining me, and I look forward to our next conversation.